So this one is going to outline a number of different things, and hopefully I don't think it's too general. We try to use a lot of examples so that this is pretty applied, because, a lot of these strengths and weaknesses you might be able to guess, but there are some things that we really, really want to highlight because the evidence that I have that these things are important is because I have received a lot of questions that show me that people don't know these strengths and weaknesses all the time. In other words, I'll get a question from somebody, hey, I was thinking about using the data to do this. And I say, there's a good bet that you're going to run into some problem, right? And if the person had known these strengths and weaknesses, they probably wouldn't have asked me because they would already have known what that problem was going to be. And so these kinds of segments, they might seem either basic or kind of dry, but actually these are real. If you want to think about them as fundamentals. These are the fundamentals. As with all of our segments, I will try to build in some time, and if you do have questions, pop them into the chat, and we'll get going here. So again, always important to remember that the data are derived, right? These administrative claims data, right, are derived from the payment of bills. And the category of administrative data more broadly, of course, is that, these are data derived from some administrative process, not because a researcher went out and designed the data the way that they wanted to, but rather the data reflect that administrative process. The functions and the features of that administrative process are some of the biggest data, or some of the data generating mechanisms that really shape what happens in the data and the strengths and weaknesses of the data. So the consequence here is because these are about the payment of bills, the submission and payment of bills, is that the information that is needed to pay the bill. So you can say, okay, this particular field or this particular piece of information, is it relevant to whether and how much is paid for this bill? Is it relevant? And I mean relevant not in a logical, theoretical sense, but is it relevant administratively? And we'll get to examples of this, but you could imagine, okay, is there a particular condition you want to study? And if there's a particular condition you want to study, is it likely to have services attached to it that would be billed for? An example of this would be something like obesity. I've had people ask me about, doing research and they wanted to include obesity either as a potential covariate or that was part of, they wanted to create their population based on that. And the issue is that obesity is a condition that doesn't necessarily have a lot of services that go along with it. And so what that means, because again, we're talking about the payment of bills for services, we need to think about, okay, is this condition, so is obesity, is it likely that when it's present, it will be consistently, if not always, at least consistently, fairly consistently, have services attached to it that are then billed for? And obviously, we've got some newer weight loss drugs and things on the market and those kinds of things. But for a long time, one of the few things that might be billed for in relation to obesity would be something like a bariatric surgery, right? And so you could say, oh, I want to do a study on obesity and bariatric surgery. The problem is that it is very likely that at least a good chunk of the people, up until we get into weight loss drugs and things, that a very large chunk of the people who are coded as having obesity are coded as having obesity because they're getting the bariatric surgery, right? It's about the service. So this is not a problem list if we're looking at people's conditions, right? It's always important to remember these are bills for services. Now, there are conditions that might be added into a claim form to adjust payment, right? And so in that case, yes, we might be more likely to see certain conditions, even if they are not the thing being treated. But we have to remember, okay, does it adjust the payment or is there a service attached to it? Is it administratively relevant? So the also means that the information that's contained is going to be influenced, as we said in the last segment, by the payment process. right? And the process leading up to payment or denial, et cetera. The enrollment data are the basis for determining whose bills are qualified to be paid. And this is one of the reasons why with enrollment data, you'd want to pay attention to that master beneficiary summary file, because enrollment data may be relevant in the payment of bills, right? So just always think, is it relevant administratively to the payment of bills? So these are, administrative claims data, at least with the fee-for-service data. They're in electronic format, and they contain information about services and payment, right? And that's, you could think about that as a numerator, and the information about persons whose services are to be paid. And you can think about that similar to a denominator. They can be combined with information about providers of care, that is, who's getting paid, area characteristics, where the patient and the care provider are located, and other useful information. So this is not to say that it's only about money. There are a lot of pieces that affect the money. So when we say the payment of bills, we're not just talking about money. There are a lot of pieces that are relevant to that we can trust with relatively good certainty. So why would we use administrative claims data? One good thing is that for at least a number of questions, they have fairly good clinical validity, again, with relation to what they actually cover. So the data, they contain information about covered services used by enrollees in the program. Things like admission and discharge dates, not times, by the way, diagnoses, procedures, source of care, etc. And a lot of these things, again, to the degree that we believe they are consistently received, billed for, etc., you can find a fairly good picture of clinical validity in terms of what's actually happening. We have pretty good validity of many of the fields in the demographic information as well. It's largely reliable and valid. Age, date of birth, gender, race, place of residence, date, not cause of death. And in some cases, it's tied or relevant to enrollment, so that can further support that validity argument. So in other words, if it's relevant to payment, right? There are some demographic variables that are not related to payment. They're still pretty good, but especially when they're related to payment, that can definitely support the validity certainty that we have. And it is possible to link the numerator to the denominator, which in this case is really good, right? We're talking about a covered population, or an eligible and covered population. And so we can derive a pretty strong denominator and information about the people in that denominator through pretty good validity, generally good validity of demographic information. Also, the population and coverage size is really impressive in Medicare fee-for-service, right? You have, over 98% of adults age 65 and older are enrolled in Medicare. The few that aren't could be things like, I don't know, I'd have to think maybe immigrant populations or something else. It'd be a pretty rare case. So that means we've got approximately 54 million beneficiaries in Medicare. So subgroup analyses, power, they come to mean different things. Depending on your cut of data, they come to mean pretty different things when you are pulling from a population of this size. And over 99% of the deaths in the US for persons age 65 plus are accounted for in the Medicare program. Just as an aside, we've been working on the Medicaid program, and we have reason to think that maybe deaths aren't quite as well covered in that Medicaid part. I'm not going to get too deep into that, but it's a fun, nerdy fact. But the coverage in the data as analyzed is now less due to managed care enrollment. And somebody actually was asking about this either at the tail end or during the break. So that Part C enrollment, the managed care enrollment, those are in the encounter data system. They are, and if you think about it, in Part C, and we have a whole workshop on that, but in Part C, you have healthcare providers typically issuing bills not to a MAC, but to a private insurer that is administering the Part C plan. So the Blue Crosses, the Medicas, those, a lot of times what you'll see is they're the ones who are actually advertising or offering the Part C plan. So they're actually administering the plan in a way that traditional Medicare doesn't get administered. And they then are doing some of their own processing. And that's why one of the reasons why we call them encounter data instead of claims data from C is because they're already kind of pre-processed by the insurer that is administering the Part C plan before they get into CMS's or Medicare's processing system, right? And so that means that in Medicare, we don't have a mixed group in the claims, at least. We don't really have a mixed group of representing the services that happen under Part C and A and B, right? So why does that why does managed care enrollment, that is, and we use a lot of terms for it. So managed care is Medicare Advantage, is Part C, all the same thing. And so why does that managed care equal a loss in our data if we're talking about fee-for-service? Well, that's because they're actually not mixed together, at least in terms of all the services and things that you would want to study. You don't see that in the fee-for-service data. So somebody was asking, so those 40% of people who are in Medicare Advantage, does that mean they're not in these data? As far as the claims and stuff go, yeah. So there is a loss there. So out of those, if you're talking 54 million beneficiaries in Medicare, 40% of them are not in these data. So there is a caveat to this. Now that still leaves a lot of people in these data. And power, statistical power, subgroup analyses, they mean something different when you have this kind of population size and coverage. You almost start kind of not disregarding, but really, and not disavowing, but kind of really devaluing the usefulness of a p-value, right? You kind of really need to pay attention to what is the point estimate, what is the range, those kinds of things, because a p-value starts to mean something very different when you get millions and millions of people, right? And so it's just important to kind of keep that in mind. It's a good thing if you want to have a model that accounts for a lot of different parameters, those kinds of things. It's good if you want to break things down into at least many different kinds of subgroups, those kinds of things. It's very good for that. But it does mean that you also need to be thoughtful about, do we just kind of take our answer from the p-value? They are cost effective to use, and they're timely. Again, considering what you get. If you were to run a research study for this many people and that amount of information about them, that would be incredibly costly to you, right? So if you think about more of like a price per chart, these are cost effective. So if you look and you kind of get sticker shock at the cost of data through for Medicare fee-for-service, it's important to remember what you're getting in that cost. All of the pre-processing that's done, the data quality assurances around many of the fields, the support you get from ResDAC. There are a lot of good things about this that make it cost effective, even if the cost it can end up being relatively high. It's cost effective for what you get, and it's timely for what you get. If you think about CCW allowing the claim to stay open for a full year and making sure you're trying to get this full final action claim. If you were to go into the data and try to process them yourself, right, you would have a bunch of different adjustments you'd have to clean up. That's kind of already done for you, right? So those types of things are also useful. But in terms of timeliness, allowing that full year means you're always going to have a little bit of a lag between the full year data that are available in the actual files and what year it is. There's going to be a lag because of that processing. But it's a good thing for a researcher in the sense that you don't have to do that cleaning or as much of it yourself. There's consistency in the reporting format. The files are the way that the data enter, the way that the information enters the data and is processed is very standardized, consistent. And the data files are available relatively quickly, as I mentioned. One thing that I did want to highlight that I just learned about is that CMS actually just released synthetic data. And I want to stress that when I say synthetic, I mean truly synthetic. They are not real. They are, as CMS says, realistic but not real. And Abby or somebody, if you could throw the link for the synthetic data into the chat. I just want to highlight this. So this is a cool resource where if you are trying to build some code and make sure it's going to work, if you are trying to test an algorithm, if you are trying to test some software, the synthetic data you cannot derive answers from them. They are not real. They've been created through a mix of machine learning, and they describe the process at the website. But we just found out about this, and so another thing that I would say that can make this cost effective and timely is you could do a lot of, and I should also say, those synthetic data, because they're not real people and real things, they are realistic looking but not real. It's a public use file, so you don't have to go through the same process that people need to go through to obtain the actual real data, but you can spend a lot of time developing code and testing your algorithms and all, you know, those kinds of things on these data, because their file layout matches the RIF files, at least as I have been told. We haven't started playing with them yet, but this is pretty brand new. And so I just wanted to kind of highlight that again, that means you don't necessarily have to obtain the data and then start figuring out whether your code is going to work. You can start trying it out early. And so that's another piece that I think can really affect the cost effectiveness of how you obtain the data and so on. So I just wanted to highlight that resource. I checked with CMS that it's okay to kind of mention that, but that's just something that I think also, again, just makes this a useful source of data. You kind of get a preview. But again, I must stress, synthetic data are realistic looking, but are not real. So they will not match if you have some national prevalence estimate of some disease. It's the synthetic data will kind of approximate something, but it won't give you the exact answer because it's not real. It's realistic looking, realistic shaped, but not real. So the other nice thing, and we've done this a lot, is the Medicare data can be linked. And that is one of the most powerful things, actually, that I think people can do, is link Medicare data with some other source. So this could be things like census or area resource file, cancer registries. So a big example here would be SEER Medicare is one source. Other providers, you could think about the VA. Medicaid is one option that I don't think people have exercised enough, is actually getting both. National Death Index, assessment data, minimum data set. So the assessment data would be for the MDS would be like for nursing homes, for example, which I think is also a relatively underused resource. The MDS in its current form is actually a really rich source of information. And then lastly, surveys. So we have the Medicare Current Beneficiary Survey. We have the Health and Retirement Study. Those are probably two of the most common. The one thing I would say with linkages is that unless you are getting something where the linkage has already been developed for you, like SEER Medicare, like Health and Retirement Study Medicare, those links are already kind of set up. They've been arranged already. The one thing I would say with linkages is make sure you have a good plan in place, and make sure that you have received assurances from all sides before you assume that a linkage will be allowed, will be supported, etc. So just make sure that you do your homework on those on the CMS and whatever other side. Make sure you do that ahead of time. So what are some broad limitations? And I should say a lot of these limitations are not unique necessarily to Medicare. First of all, of course, conditions have to be diagnosed in a claim for services. And so they have to be diagnosed in a claim for services. All of those have to be true. And again, they might be diagnosed as a way of adjusting the claim or something that is relevant, to the claim or to the treatment of the main disease. So even if it's not the thing being treated, it might be in that claim form. But what you have to ask is it likely to be in the claim form? Is it relevant to actually adjusting the payment of that bill? So things like hypertension, very, very, very common, almost ubiquitous in the Medicare population. Depression, diabetes, also both very common. They're often underdiagnosed. And we're going to see some really interesting implications of that tomorrow in the chronic conditions segment. So in an older population, and this is going to kind of preface this a little bit, what might we think that the absence of a very common diagnosis could mean? What could that mean? Well, maybe it means that if a person does not have something, possibly it could be because they don't have good access to care, or because they avoid care. They have in some way a low propensity to receive care, possibly. It might mean they don't have it, but if it's something that's very, very, very common, or something that is very expected and we don't find it, we have to remember that does not mean it is not there. That means it is not there in the data. Those are two very different things, right? So this is a measurement error issue in some ways, definitely a bias issue in some ways. And we just want to think back to the data generating mechanisms that could lead conditions that are very, very common and maybe present in an individual to not actually be coded in a claim for services for that individual. It is a record of care received, not care needed. So this is an access to care problem, right? If people do not have good access to care, or if they're trying to get in and they haven't been able to schedule an appointment, something that I think a lot of people have run into, that means that what we have is a picture of care that is received. We don't really have any picture of care that's needed but not received. And this also has implications then down the line. So we don't know necessarily disease recurrence. We know that they got new treatment. Now, there might be a code for recurrent disease, and if you think it can be consistently applied with good validity, then you might trust it. But if what we see is essentially new treatment and we don't have any clear message on recurrence, we don't exactly know what's going on. Did they always have it and they just dropped off of treatment for a while? Did it actually go away and recur? We don't always know that, right? We can make some good guesses, but our level of certainty is always going to be a little bit questionable. The lack of access and high volume of treatment are both sources of error. So there's lack of access. There's also the problem of over-treatment, right? When treatment occurs without, where either the risks outweigh the benefits or there's not a clear benefit, and yet it keeps happening, right? So you could think of services that people seek out where the volume of what's happening in the data doesn't necessarily reflect the actual level of need, right? And so you could think of it as a Goldilocks issue, right? If some people are getting a lot more care that they don't necessarily need all of it, and other people are not getting the care that they need, there's going to be some group in the middle, but the only one that we'd be getting a good validity on would be the Goldilocks group, the just right group, where they actually match, where the need actually matches what is received. And so it's just something that we always have to kind of think about. Services that providers know in advance will be denied will be inconsistently submitted as bills. So if there's a service that providers are frequently denied on, they may still provide that service, but they may not issue a claim for it to be reimbursed by Medicare because they have a good sense that it's going to be denied. And therefore, that means that, again, we have other kinds of decisions in the real world that are actually affecting what the data look like that aren't necessarily about, a clean line between a service, a bill, and then the data. Another thing is that our coding systems are, let's say incomplete, can be. So a cancer diagnosis, for example, can be found as an ICD-9 or ICD-10 diagnosis code, but not stage or histology necessarily. So we don't necessarily get a good picture of severity. Knowing that someone has a chronic disease doesn't really provide much information about it, and necessarily about how long they've had it. So we can look at when claims are happening. We don't necessarily know that it wasn't there prior to those claims happening, et cetera. So the idea of really getting a clear picture of incidence versus prevalence is always a little questionable. And again, as I mentioned, severity. The other thing to think about is that many drugs and procedures might have multiple indications. So an example here would be antidepressants. We were doing a study trying to identify, making sure that we didn't lose anybody who had, being as sensitive as we could to find depression. And somebody brought up the idea, well, we can check for antidepressants. And there are a couple of issues with that. The first is that if somebody is receiving an antidepressant for depression, they probably will have depression coded. So it's not necessarily going to get us any new cases that are truly depression. The other thing is that antidepressants are used for all kinds of things. And so if we went looking for antidepressants as an indication of depression, we're going to have not a sensitivity issue, but a specificity issue. And then there are no diagnoses in the Part D event file. So that's why, we can't just kind of use drugs to, make some kind of indication of the presence of a disease. So what the picture we get is that if we believe that a condition is likely to be added on a claim form, either for services for that condition or as an adjustment kind of on a claim form, if we think that that's going to have good consistency, good validity, we can probably trust it, but we don't really have any assurance about that from the data themselves. So that's kind of a theoretical issue. It may be an issue we can kind of benchmark empirically using other data sources to say, okay, are we really being sensitive enough, et cetera. The data themselves are not going to tell you that. You can issue, you can apply all kinds of algorithms and choices and things like that and really try to fine tune things, but you're never really going to know for sure because you only have what you have in the claims data. Different care settings use different coding systems for procedures. So here's a fun thing, right? So inpatient care is coded using ICD-9 procedure codes or ICD-10 procedure codes. Carrier and durable medical equipment are coded using CPT codes and HCPCS codes. We'll get, I think, more into these, but I'll hit them on this slide too. Hospital outpatient care is coded as a mix of CPT and revenue center, that is hospital billing center codes. And there is a less than perfect crosswalk between a lot of these things, particularly on the procedure code side would be an example. So I should do a poll for this. But to go through all of these, consider where these codes come from. So maybe we can use it in the chat. Somebody want to put in the chat, where do ICD codes come from? Who makes the ICD codes? There we go. Okay, we're getting some. When I said who makes the ICD codes, that wasn't a question. It's the ICD codes are issued by the World Health Organization, and then they are further versions that the United States uses are further processed by different government contractors. That's why you sometimes see people say ICD-10, ICD-9 right? That's clinical modification that's done by a particular government contractor for the United States. This is why the rest of the world is ahead of us, or has been ahead of us historically, on ICD code application. Why it took so long for us to roll onto the ICD-10 system was because all of the people in the United States that were doing the work were saying, we're not ready, we're not ready, we're not ready. I don't know if that was an excuse or not, but that's why we lag behind the rest of the world. Yes, yeah. So it's actually the World Health Organization codes are translated into ICD, and this now ICD-10 for diagnoses and ICD-10 PCS for procedure code systems by these government contractors. So think of like I'm not going to list a bunch of names, but think of like a 3M or some other large company that contracts with the government to do different things. That would be the kind of work that would happen, is those clinical modifications, or under the new system, it's not just CM, it's CM for diagnoses and PCS for ICD-10 procedure codes. So that's the ICD codes. Who creates the CPT codes? Good. Okay. American Medical Association. Very good. Right? The last one, so that's the American Medical Association. The last one is HCPCS codes. HCPCS codes, I'm not going to get into too much in terms of exactly how they're created, but the point of the HCPCS codes is that CPT codes are level 1 HCPCS codes. The issue is, of course, what about all the other procedures that are done by non-physicians, for example? What about ambulance codes? Those go into level 2 HCPCS codes. So there's level 1 and level 2. We've got huge manuals in our offices about that thick for CPT codes, for HCPCS codes, for ICD codes, and we actually had to get rid of a couple of them because there were some that aren't even in the data anymore because they were from 1997 or something like that. We just did that this week. So we have also, there's a good reason why there's just not a good crosswalk, because these are different bodies creating these things, right? And so just keep in mind, ICD, who created the ICD is not a question. CPT codes are created by the American Medical Association, which of course generally is going to leave out non-physician services. And so that's why we need 2 levels of HCPCS codes, with the first level being CPT, second level being level 2 HCPCS codes to capture a lot of those other things like ambulance services and labs and other things. So hospital outpatient care, then we've got those revenue center codes, right? And so I think you'll be looking at some of those in some of the later data examples on, like, how would you, for instance, identify an emergency department visit, revenue center. So those kinds of things. And again, there's just not a good crosswalk. Okay? So this is one thing that you really need to learn how to navigate. And that's why we have those giant manuals in our offices in case we need to look something up. They're not always publicly available on the web. Billing codes change over time. So alphanumeric HCPCS codes used for identifying for screening mammography. Well, what happened from end of the year 2017 into 2018? I guess we just stopped doing mammograms? No, of course not. The coding system changed. And we see things like this. This is why when I was saying earlier, when you see a sharp change, make sure you've got all your codes right, because coding systems change, especially things like CPT and HCPCS codes. You definitely will see changes there that are not because clinical practice changed. It's because the codes being used changed. Aha, new codes. Where if we look overall, we actually get a fairly consistent picture on mammography across these. And note that there's some kind of sharp looking changes, but that's by month, right? If we kind of average those out over the years, that would be pretty consistent for the kind of, and that's usually what you see is it's actually a lot of consistency for many, many things. Also, again, you do have very limited clinical information. This is why, similar to severity, often you don't get things like, well, you can see that maybe a blood pressure was obtained. You don't know what it was. You don't know pulse, ejection fraction. You know that a test happened, but you don't know the result, right? So PSA, angiography, pathology, etc. You might know that they happened, but you won't know the result. And so sometimes for, let's say, clinical outcomes research, you really have to be thoughtful about whether these kinds of data are useful for that or not. Also, this is one thing that sometimes people are surprised about and sometimes not, but exact timing is not included. We don't have timestamps the way that we do in the EHR. And I think in some ways that's probably sensible, because again, if we think back that these are for the payment of bills, right? The exact time of day is often less relevant, but we do see a lot of studies on people looking at, what happens when somebody comes in on a weekend, for example. So we do have days, just not hours or minutes. So we don't have good timestamps. The other thing that can run into is things like the time of day for an ER visit. So you don't know if somebody came in the morning, the evening, et cetera. And if you see a couple of different ER claims, does that mean that they came, left, and came back? Possibly. You don't necessarily always know that for sure. And so in a lot of cases, a lot of the counting algorithms that people use, actually what they're doing is actually counting days with an ER visit. So it could be days with one or more ER visits. So they might actually be counting more like okay, this is an ER visit that happened on this day, but if we see two of them, we're only going to count it once because we don't know exactly for sure, right, whether that was actually a new ER visit. And so in a lot of cases, if you see counts of ER visits, that's actually the algorithm. The algorithmic logic is, hey, we don't have the time, so we're just going to say, yeah, an ER visit happened on this day. Could it have been more? Yeah. And that's kind of what we're left with. So you just have to kind of think about the types of questions you're going to ask, and what kinds of things are possible, and whether those two things align. Prior to Part D, obviously, you need to think about for when claims are submitted, right? They apply to covered benefits and which claims are submitted. So if you want to think about something like medications, prior to Part D, Medicare really didn't really have a pharmacy benefit. So outpatient medications really can't be studied with good certainty, mostly across the board, right? With Part D, studies still have to take formularies into account. Covered services for which claims are not submitted are not included. So if you can think about something like an immunization clinic, if somebody went and somebody was running an immunization clinic, say for COVID-19, and a person received a free shot, even if they're covered and eligible, if that immunization clinic was not collecting people's insurance information, or the person didn't have their card with them or whatever else, during times when, say, something was free, relatively speaking, so people with insurance were certain, their insurance might still pay for it, but for people who didn't have insurance or other things, they might still get a shot, right? Well, if you're in a clinic like that and they don't happen to get somebody's, say, Medicare information, then even if they're covered and eligible, you wouldn't know it. Right? And so we have to always go back to the idea of, do we think that this thing is likely to be billed for or to appear on a bill? Some services are not covered. So one thing, you can go to the Medicare coverage database. Medicare coverage decisions or national coverage determinations can actually change what is covered overnight. There's obviously some activity leading up to them, but you might see in a graph, all of a sudden, within a week or two, all of a sudden, some type of service is happening way less. You say, what is that? And then you realize that, a coverage determination made a new service coverable, and providers switched to that one because it was the new hot thing. And if you didn't include that, or if you're trying to study one or the other of those services, your picture is going to be pretty skewed depending on when the national coverage determination happened. An example that we ran into with this was we were looking at bariatric surgery. And if you know, bariatric surgeries are not one thing. There are multiple kinds of procedures. And one of them, sleeve gastrectomy, became eligible for coverage during an observation period. And the thing was that after our observation period. And so we had our results. We were trying to put them, publish them about, like, here are the types of bariatric surgery and here are the outcomes, et cetera. The problem was it was hard to get published because sleeve gastrectomy was now available, but our data didn't include it because a national coverage determination had been made. And so now our study kind of, not fully irrelevant, but it's really not timely anymore because of the availability of that particular procedure. So try to stay up to date with those. And again, that's a contextual thing that usually you're not going to get any kind of clear answer from the data themselves. We don't have great information about Part B services for managed care enrollees. Again, if you think about, like, if you get in managed care enrollees, the types of Part B services that somebody might accrue here or there, we don't really get that. Those are managed care enrollees, right? Little information about hospitalizations for managed care enrollees as well. Now you can look in the MedPAR, and I think some people have done that. But we up till now, we haven't really had because of the relative newness of managed care encounter data, we haven't always had a good picture of the quality of those data. I think there's been more work now, and we can probably update the site a little bit, but for a long time, and still a little bit, we're just not quite sure about whether we're getting any good information about hospitalizations for managed care enrollees, if from something like the MedPAR, for example. Not all beneficiaries have Part D coverage. And I did put in the chat like quite a while ago, in answer to somebody's question about Part D. Beth and I did a report for ARC a while back where we did look at Part D coverage, and the Part D population is not only not everybody in Part A and B, it's actually a biased subsample. If you took people who have Part A and Part B and then compared them with people who have A, B, and D, they're not the same, they're not equivalent populations. And so that's another thing to kind of keep in mind. But not all beneficiaries with Part D coverage will have Part D utilization information contained in the files. We did see a number of people who were enrolled in Part D and did not have any Part D information. And that could be a number of things. One example is somebody might have become eligible due to a low-income subsidy for Part D and didn't know it. So somebody might be enrolled and not know it, or not know how to access the benefits, those kinds of things. So the quality and validity issue is there are things that we can trust, and there are things that we can be less confident about. And so to go back, that general rule is if it impacts payment in some way, whether it is the thing you're getting services for, whether it's the service itself, whether it is the person providing the service, whether it is the person who is eligible for the service, whether it impacts the payment amount for that service, those things are always going to be of better quality than things that are not impacting payment. Also, different types of care may be subject to different payment rules. And lastly, we can't say this is the amount of measurement error you can expect across different variables. It really is a theoretical question largely. And secondarily, you might be able to benchmark against some other data that you have. Not in terms of a linkage, but just a comparison. That's about all you can do, right? Beyond that, it is a theoretical issue of whether, again, you think, is this likely to consistently impact payment? In general, the data elements that are provided by CMS provide consistent information. The data dictionaries, record layouts contain information about some assumptions, some data combinations and things. These are very important. So make sure, again, as you would think most people should, pay attention to data documentation, data dictionaries. You should have those with you and ready so that you can kind of cross-reference any variables or fields that you happen to be using for your project to see whether they have any notations on them. Another thing that happens is we do get questions through our user support. People will find very strange patterns in the data that are very unexpected. And they'll ask us, is this just my kind of data, or what's going on? And we'll kind of scratch our heads and sometimes have our analysts look at it, but sometimes the data are just quirky. You'll think that so one good example is provider identifiers. If you actually looked at, there are a number of different variables that are used as provider identifiers, some for institutional providers, some for individual providers. Sometimes those fields are very well filled out and complete, and sometimes they're not. I can say that I've run into the issue of institutional providers, health systems, that kind of thing, being fairly complete. So you could track whether somebody's in the same health system, but tracking them across individual providers to see whether they actually, whether they had really fragmented care on individual providers, we ran into some trouble with that. Now, that was Medicaid data, but I believe we've looked at the Medicare data and found kind of a similar pattern there. So it's just something to kind of think about, that, you really want to think about also whether the data documentation gives you some indication that a variable you're really counting on is actually, of good quality or completeness, or has any issues that have been identified, again, at least in those data dictionaries. So just be thinking about, are there things that I'm counting on that I'm actually not certain about as they exist in the data? Maybe I shouldn't count on them. Maybe I should do some homework and check. those kinds of things. And of course, there are plenty of other challenges. The structure of Medicare data is complex, and it's different from most other data sources. So yes, each person has one enrollment record per year. Each person has, though, a variable number of hospitalization records per year, because of course, hospitalization numbers, counts aren't consistent across people and years. Each person has a variable number also of all of these other types of records per year, because it's based on utilization. And each of those records is divided up into multiple files. So again, a person's a given health event can exist across multiple files. And events may need tracking across those different files. So just thinking through about what each file contains and whether some services might have been billed for that particular file's relevant provider or setting is a part of the process of thinking about which data you need. And we can move through this fairly quickly. So first, we need to define the population if we're going to use it, and a clear definition of it is needed. But an important rule, you've got to think about making sure that all persons in the denominator are eligible to have events. Right? Otherwise, you're getting a larger denominator than what you need, and you don't have good positivity, for example. Location, if you're thinking about that, defining your population, is it continuous? So if you say, I want them to be in this state, ever, the whole time, those kinds of things. What about people who are newly eligible? Well, they wouldn't be having the same location all the time because they weren't there the whole year. Deaths, similar issue, different side censoring. What about people who move? Those kinds of things. Diagnoses and procedures. Again, if you're defining more of a clinical population, there's rarely a single simple diagnosis code that you can just put in as a rule and have that be it. Many similar cases are going to have a lot of different diagnosis codes that could apply to define that population. One real thing that I would just also note is that among those multiple diagnosis codes, the not otherwise specified code. So depression not otherwise specified, or other fall, or those kinds of things, that kind of those catch-all categories, you're probably going to want to include those too. And then of course, you do need to think about how each of these is going to impact your population of interest and the shape of the cut of data that you get. So demographics are relevant, but you can also go beyond that and think about, okay, did they have Part A and Part B both for the whole year? Since Part B is like this optional thing, maybe they didn't want that, maybe it switched on, those kinds of things. Part D, did they switch over to managed care? All of those things. You need to think about, okay, it's one thing to say, I want that, but it's another thing to say, okay, but how does that apply? Do you mean any month or the whole time continuous, right? Is it ever or always? Those kinds of things. Similar benefit program, if you're really interested in the aged population, old age eligible population, then you'd probably want to actually limit your request to that, because those eligibility populations really do vary. Then defining outcomes of interest, we need to think about all kinds of things, but is it the receipt of a diagnosis? Is it days until an event, or a duration, like a length of stay? Are we thinking about death? And a note there that's important is that cause-specific mortality can only be studied in some years, and it's actually a ways back now, because we have date, not cause of death. We have death dates that are pretty good, but not cause for all years. Healthcare use. Do you want to think about something that's where you use an algorithm to say that, well, we think theoretically that these things were avoidable, those kinds of things. And of course, there's money spent, which we will talk about in a few further segment. And so then we just need to kind of think about studying time trends, going back to all the things we mentioned about major changes that are not necessarily simply because of changes in clinical practice or clinical thought. So I mentioned diagnostic related groups. Medicare managed care penetration over time has become really big, even bigger in Medicaid in a lot of places. Changes in granularity and availability. For example, there are actually two different variables that measure race. One has been adjusted, that's actually kind of recent, that's been adjusted based on some early work that Beth and others have done. Also things like mechanism of injury codes. This goes back a ways, but for a while, E-codes in the ICD-9 system, prior to like 2011, they weren't super complete, right? Because more space was made available for them after them. Part D coverage, obviously, and you could imagine the examples in Medicaid, like Medicaid expansion. Coverage of payment policies for specific procedures, and I gave that example for bariatric surgery, and of course changes in coding systems, especially things like CPT and HCPCS codes. And of course we've got demographics, location, comorbidities. You want to confirm that your important covariates can be found. That is a really, really key thing. If you are counting on something, make sure it's there. Check ahead of time. So you want to go wide enough, but we also have this rule about minimum data necessary to answer the question. So there is a little bit of a balancing act to make sure that you get enough to answer your question and don't have to go back and ask for anything else, but also balance that against minimum data necessary to answer the question. And so you just got to spend a lot of time carefully defining it for analysis. So you don't need records. If they're poorly defined, you're not going to really get a better answer. It's just adding noise. So sometimes we mention to people, consider actually limiting the scope of what they're trying to do to maximize the confidence that you can and the rigor that you can apply. All right. And I think we went long, but do we have any questions that we haven't addressed in the chat?
So a lot of the questions we're going to be discussing in other segments, like there's a lot of residents and when people move, and we'll talk about that in the MBSF segment. There was one question that I think kind of goes to like kind of basics. So the question was, so could you use the procedures and prescriptions build to build a cohort of the obese, which is something we kind of talked about at the beginning.
You could build a cohort of the treated obese. Let's put it that way. People have to seek that out. It is not necessarily something that is going to affect payment for other services. And so you could look for, a whole swath of the kinds of treatments or procedures that might be done for obesity. The catch is that then your population or your denominator, or how you want to say that, your analytic sample is a sample of people who have been treated for obesity, not people who have obesity. And those, of course, are different groups, right? There may be people who had the means, there may be people who had the inclination. There's all kinds of reasons why people get treatment and don't. So I would just say you could get a grouping of people who have been treated for it.
And one quick one about when are ICD codes versus CPT codes versus HCPCS codes used?
Yeah, and we kind of went through that. So the ICD codes, so one thing to keep in mind is that CPT codes are procedure codes. So one thing to keep in mind is that what we're really talking about is what are the procedure codes. Diagnosis codes, it's going to be a variation on the ICD codes. But procedure codes, and Steph, correct me if I misspoke, we have a slide on it, but inpatient hospital is going to be ICD. Outpatient hospital, I think, is going to be a mix. Carrier file is going to be CPT typically, or other HCPCS codes. Does that sound right?
Yes, yeah. Outpatient is HCPCS code based, but they use that to kind of calculate HCPCS they call it. Yeah, and then inpatient is using the ICD diagnosis codes. That's right, and then
and the ICD procedure codes, correct?
And the ICD procedure codes. I'm sorry. Yes. Yep, that's right. And yes. And when we say HCPCS, that includes CPT codes, like you said.
Yep. And that's, yeah. So the other thing to think about is when is a HCPC not a CPT, right? So HCPCs are CPT at level 1, and any typically like non-physician services will be level 2 HCPCs. They're not CPT codes anymore, but they are the HCPCS coding system. So CPT is level 1, other HCPCS types of, procedure codes are level 2.
And yeah, as we go through and talk about the individual claims files and the services that are billed within each one, then we'll elaborate
that's true. We'll see
on how they fit in. Yeah, so we'll talk about the APC codes, and then we'll talk about the ICD-10 versus CPT. When are those being used? So I think that we will get into those questions. So I guess, yeah, some of the answer is stay tuned.